Are you a hospital educator trying to get together an orientation program for your critical care and acute care nurses? That is a huge undertaking, and you could join me, Cam and Christy, with MedEd. Is already the whole orientation program is done with objectives, references, great lectures. People who are experts in the field have put it all together in one solid program. It will help you so much because you don't have to start from scratch.
Hello and welcome to MedEd's production of Nursing Excellence Training. My name is Lisa Soltis and I'll be your instructor. This is part of the cardiovascular section, and this module will be looking at management of advanced heart failure. So in our previous module we talked about patients, the medical side and medical management of heart failure, and this time we're going to talk more advanced treatments associated or required for patients that have heart failure. So some of the contributing factors to the development of heart failure are patients that develop cardiomyopathies. We had described the dilated cardiomyopathy. This is typically what we see with patients that have the systolic dysfunction, typically with a decreased or impaired ejection fraction. With that, there's lots of volume inside the left ventricle, but the decreased systolic function then causes a decrease in their ejection fraction, decrease in cardiac output, and stroke volume with that. Complications associated with a dilated cardiomyopathy include, again, thromboembolism, and that's why anticoagulation therapy is indicated for those patients. Dysrhythmias, as we described when they develop bundle branch blocks or atrial fibrillation, and they're also at higher risk for developing a sudden cardiac arrest. Most common cause of a dilated cardiomyopathy is associated with an ischemic event or ischemic heart disease. With a hypertrophic cardiomyopathy, again, it can be idiopathic, which is what we see sometimes in younger adults. From an older adult population, then typically what we'll see is a thick, dense, hypertrophied ventricle that becomes very thick. They have a normal ejection fraction, but there's decreased volume within the ventricular cavity. So even though they've got a normal systolic function, they have impaired filling, and that leads to, again, a decreased cardiac output. They'll have more signs of fatigue, shortness of breath, progressive left ventricular failure, also at risk for developing atrial fibrillation, and that will certainly impact their cardiac output as well. So the overall picture is a small ventricular cavity, but a normal ejection fraction is associated with that. Restrictive cardiomyopathies, then, this is something that we can see with our right-sided failure, where again we have changes to the ventricle and how well it functions. If it becomes stiff, sometimes they'll see tachycardia, peripheral edema, ascites associated with that. Liver engorgement is a common finding with right heart failure. They've got restrictive filling. They've got reduced diastolic volume, even though they may have normal wall function on the right side. Also leading to dilation of the atria when they have a restrictive disease, because if the blood isn't moving forward, it's going to back up into the left atrium on the left side. It'll back up into the right atrium on the right side. And so again, that can contribute to the development of mitral or tricuspid regurgitation or insufficiency, and that affects obviously how well the blood moves forward to the next chamber. Stress-induced cardiomyopathy is another type of cardiomyopathy that we're starting to see. It's also referred to as Takotsubo. With a Takotsubo type heart failure, sometimes people call it the broken heart syndrome. This type of heart failure is an acute onset. Many times patients will present with chest pain and it looks like an ischemic event, and then echocardiogram will show that they have an akinesis of the left ventricle. Most common patients that present with a Takotsubo or a stress-induced heart failure are typically postmenopausal women that have experienced some life event or some stressful event, whether it's loss of a loved one or a death, loss of a job, relocation. Any type of life event that would cause significant stress can lead to this. The reason it's called Takotsubo, Japanese physicians that first did research on this, is that normally when the ventricle empties, it empties from the apex or the base of the ventricle up. and it squeezes from the bottom, pushing the blood forward is normally how it squeezes. With Takotsubo, the muscles at the top of the ventricle are still functional, but the muscles at the apex become akinetic, which means they don't move. And so the ventricle actually changes its shape and becomes more of a bowl shape. And so Takotsubo is the name or the word for octopus pot. And so the octopus pot that they use to capture octopi is a circular bowl with a lip on it, and that's almost what happens to the ventricle. So now the bottom isn't moving at all and it gets more of a rounder shape, but these muscles are still contracting, but they're contracting downward. So now instead of pushing from the bottom up and injecting the blood forward, they're just kind of moving from the top and pushing down a little bit, and so obviously that's going to impact their cardiac output and the forward flow of that blood. Management for these patients, again, we're going to manage their symptoms and supportive as far as with bed rest and their fluids and oxygenation, and then just continue to ride it out until recovery. Recovery can take anywhere from 2 to 4 weeks, but usually they have a full recovery, and the likelihood of them having a second event of Takotsubo is pretty rare with that. So we are starting to see more patients presenting with those types of symptoms. So management when patients are hospitalized with advanced heart failure. Obviously, IV diuretic therapy is important. So no longer are we giving the Lasix every morning and every evening, but they may be on a Lasix drip or a Bumex strip. So much more aggressive diuretic therapy to manage their fluid overload. Additional agents as far as other aldosterone antagonists. Again, very careful, cautious management of their electrolytes because diuretics are going to affect those electrolytes, and we want to make sure that we don't have any lethal arrhythmias that result from electrolyte imbalances with that. And then they can also look at, some facilities have the ability to do ultrafiltration or aquapheresis, where we are able to pull plasma volume off, but it's not like a dialysis type picture where we're not changing solutes or electrolytes or concentrations of solutes within the blood, but we're just pulling off fluid volume strictly with that. So when we look at ultrafiltration or aquapheresis, again, it's removing circulating volume out of the blood and out of circulation with that. So there's no removal of solutes, only water is removed from the body. And depending on the device that's used or the equipment that they have, can remove anywhere between 500 mLs to a liter an hour can be removed. So again, short-term therapy to help during an acute exacerbation. We pull off that extra fluid. And the other nice thing is that it can be run off of a peripheral IV access, so it doesn't require a special tunneled cath or invasive catheter to be able to perform this type of procedure. So some of these devices that one is kind of in the forefront of the picture, but most of them are fairly small, so about the size of a IV pump, and then it's hooked to the peripheral IV, and then patients basically just sit in bed while the treatment is run. Nurses then have to go through additional training and education to become competent and qualified to be able to run ultrafiltration or aquapheresis, and so that's going to depend on the policies and regulations in each organization and each hospital where you may work. Cardiac resynchronization therapy, so patients that are developing a wide QRS complex, a left bundle branch block, a low ejection fraction. By doing the cardiac resynchronization therapy, then we improve the synchrony between the two ventricles. You get more effective emptying of the left ventricle. If the right ventricle is squeezing before the left, it's going to displace the septum, so now you've got the ventricles basically pushing against each other. And so if you can get them both squeezing together, you get more effective emptying on both sides. And so again, another important part of management of advanced heart failure. And then the advent of mechanical circulatory support and the advancements that have been made in circulatory support over the last 15 to 20 years have been absolutely profound as far as the types of devices, the size of the devices, as well as indications for them. And so it's really exciting to see some of the treatment options that are available for these patients with heart failure. So patients that they would consider mechanical circulatory support, this would be our stage D patients with heart failure with a reduced ejection fraction, or our systolic heart failure patients with that. And so it can be utilized if we anticipate this patient is going to move towards transplantation. It can be a short-term device, or if we have a more durable medical or mechanical circulatory support with that, then we can utilize these devices then to prolong survival. So they may not be a transplant candidate, but it will definitely improve their quality of life. Many patients that come in stage 4, class 4 and stage D, so very advanced heart failure, and they can put in a device and the patients go home with that device, and when they leave the hospital their symptoms have improved to stage 2. So again, significant improvement in their quality of life as well as longevity. Non-durable mechanical circulatory support, where we expect full cardiac recovery. So if it is a patient that has myocarditis, some sort of cardiogenic shock, or any type of injury to the heart where they just need short-term support until the heart muscle can recover, and so then we use the non-durable options for those patients. The ventricular assist devices then are different various forms of mechanical circulatory support with that. So they can support both right heart failure as well as left heart failure. It supports both pulmonary circulation as well as systemic circulation, so depending on the patient's indications, and again can be weaned based on the patient's intrinsic response. So how much of their cardiac function they still have, and if their cardiac function improves, then we can wean down the amount of assistance that we're providing to the patient. So why use a VAD? So we typically refer to them as a ventricular assist device or a VAD. Again, when we look at our post-cardiotomy shock, cardiogenic shock, myocarditis, in this indication it would be a bridge to recovery. So it means we're putting it in to support the patient, support perfusion to their other vital organs until the heart recovers, and then we explant and take the VAD out. If it's end-stage heart failure, then again, it could be a bridge to transplant. So now we put this in. The beauty of end-stage heart failure in a VAD is that when they're stage 4, class 4 or stage D, and they are not perfusing well, their lungs are in failure, their liver is in failure, their kidneys are in failure, they're not mentating well because everything has decreased perfusion. When you put in a short-term assist device or ventricular assist device that supports perfusion to the lungs, so oxygenation gets better, supports perfusion to the liver, and so the liver function returns, supports perfusion to the kidneys, so the kidneys become happy and they start to clear the solutes like they're normally supposed to do, and so we'll see an improvement in their renal function with the use of that. Then patients are much stronger and in a better physiological state to tolerate surgery for the transplant, so that the success rates for transplantation after the use of a VAD are much higher because the patient's in a better physiological state to tolerate the surgery itself. We can also use a VAD then, as we said, for a last resort for patients that is not a transplant candidate, but it does help improve their quality of life and their longevity and survival, prolonging their survival. And so this would be considered what we call destination therapy. These devices are implantable. They have a drive line that comes out through the abdomen that either is connected to the console or it's connected to a battery pack so that the patient can become mobile and untethered so that they can move around. And those machines then support circulation, and the heart basically acts as a reservoir while the machine does all the work for those patients, and again significantly improves their quality of life. So looking at transplantation, as we said, the bridge to transplantation, the end-stage heart failure, advanced myocarditis, or large MI, to stabilize patients so that they can be in a better state to tolerate the surgery itself. Earlier use of VADs shows better outcomes, so it's better to start talking about a VAD sooner rather than later, because if we wait till later, they've already started down that road of long-term complications associated with heart failure or decreased cardiac function. The bridge to recovery then, again, where it's an acute insult to the heart, so there is the opportunity for the heart to recover, and so it decreases the workload of the heart, improving cardiac output. And then the destination therapy, as we described, improves the quality of life. I've had experience with patients that survived 5, 10, 12 years with their ventricular assist devices at home, and so again able to see their grandchildren graduate from college or whatever the situation may have been. So the concepts of a ventricular assist device is to help provide systemic perfusion. It helps decompress the left ventricle by as much as 40%. So again, the heart kind of acts as a reservoir while the machine does the work and does the perfusion. Most VADs, then, the lungs still do the oxygenation, and we just unload the left side and have mechanical support that typically then will connect to the aorta and then perfuse the rest of the body in that measure. Decreases wall stress on the ventricle. So again, if it's an ischemic problem, myocarditis, cardiogenic shock, it decreases the wall stress by more than 80%. So significantly decreases the risk of additional damage to the heart with that. Also decreases our myocardial oxygen demand and oxygen consumption. So our consumption decreases by almost half, down 40%. Because it is a mechanical device and an artificial circuit that is being utilized, then anticoagulation is necessary. So another consideration, looking at patients that are high risk for stroke or high risk for bleeding, again, weighing very carefully the benefits and risks with any type of ventricular assist device. Many times we can put in a left heart support, and then as we unload the left side and clear out the lungs and get them oxygenating better, and then we realize their right heart isn't functioning so well. And so sometimes then when we improve the left side, then we uncover that there's actually a right heart problem as well. So many times we can then add an additional device for right and left sided support if indicated. So again, when we unmask and unload the left side, then it may make it more apparent that there's a problem on the right side as well. Some of the devices, these next few devices are considered short-term support, and this first one is called a Tandem Heart. It is basically inserted through the femoral vein, and it goes up through the into the right atrium. They create a perforation through the septum, and so then the device then is over on the left atrium. So again, it's designed to be a short-term circulatory support. So patients that have gone for like a catheterization or where they need additional support during the procedure, then that can certainly help with that. So it's designed to be a short-term support device. The Abiomed Impella is another similar device, but this one is inserted through the femoral artery. It is then threaded across the aortic arch and then down into, in a retrograde flow, into the left ventricle. The pigtail on the end is to make sure that there isn't any damage as it's being inserted into the left ventricle. And where that bend is that you can see, that is actually where the motor housing is. And so that bend is typically where they want to put that across the aortic valve. The inflow, which is basically near the pigtail, so at the very end, the inflow valve is basically, there's a microaxial pump on the inside, and so it sucks in the blood, and then the outflow is actually right where the catheter turns white. So it pulls it out of the left ventricle, and then it ejects it into the aorta. So now it's sitting across that aortic valve, so it pulls it out and then ejects the blood into the aorta. So depending on the size of the device will determine how much cardiac support that you receive from that. So anywhere from 2.5 to 5.0 in varying sizes. So it can, the smallest one can generate up to 2.5 liters of flow. The largest one, obviously, up to 5 liters of flow. Again, designed to be a short-term support device. So patients that, again, failed catheterization or some sort of myocarditis or other types of things where they just need short-term support, it can be inserted percutaneously through the femoral artery with that and supporting circulation. Indications, as we said, again, when they have reduced left ventricular function, post-cardiotomy syndrome, cardiogenic shock after acute MI, our high-risk PCI patients, or if we have a patient that's going for a CABG, the coronary artery bypass grafting, and they've got an impaired ejection fraction, this can provide additional support percutaneously for the patient in the post-op period. So again, looking at a closer picture of the Abiomed, the inlet area there is just past the pigtail, and so again, that's where the blood enters the catheter. Within the catheter itself then is this microaxial pump that is basically spinning, creating that suction that pulls the blood out, and then it ejects it past the bend, which is then typically seated somewhere on the ascending aorta. So again, supporting systemic perfusion that way. Some of the contraindications for the Impella, if they have a mechanical heart valve, especially in the aortic position, then we certainly don't want to be putting another mechanical device in a mechanical valve. If they have any significant aortic stenosis or calcifications, because you're threading that across the aorta in a retrograde fashion into the ventricle, and so if they come in contact with any of those calcifications, then you run the risk of rupture or some of the calcifications breaking off, and then the risk of an embolic event leading to stroke. If they have moderate or severe aortic insufficiency, you're not going to have great clinical effect as a result, because if the aortic valve isn't closing, it's going to be pulling and pulling basically in very close proximity without that closure of the aortic valve, and so it'll minimize the amount of effect that we would normally be able to achieve with a closed or functional aortic valve. And then also if they have severe peripheral vascular disease, if they've had aortic bifems, peripheral arterial disease, so they've already had bypass vascular surgeries or other things like that, we want to make sure that that they have ability to properly access and implant the device that way, versus if they have severe vascular disease, we certainly don't want to compromise perfusion to the lower extremities. So patient management, because the last two devices are inserted femorally, so we don't want to raise the bed above 30 degrees. So again, we can look at reverse Trendelenburg to try and help improve patient comfort, but we really want to minimize the amount of bend in the groin and at the waist. Sometimes using a knee immobilizer, because many times people want to bend their knee and hike their foot up, and then that can cause, again, a bend in the femoral artery with that. We always want to, anytime we have a sheath in or any type of groin access, you want to make sure that we assess for bleeding or any signs of a retroperitoneal bleed or hematoma formation, especially after the procedure, and we're looking at removal of the sheath or the access catheters. We want to be very careful as far as when we de-access those lines. Be careful not to, lean on these devices or touch the device, making sure that we keep the equipment safe so that there aren't any accidental pushing of buttons or anything like that. And sometimes if we're moving them from one bed to the other, making sure you have plenty of staff so that one person, all they do is make sure that they stabilize the catheter, and that patient's leg as we move them over to make sure that it doesn't migrate at all with that. Making sure we monitor their distal pulses, extremely important, because we don't want to develop limb ischemia. And then also the monitoring screen for the Impella specifically also gives us more information as far as the pressures and the flow waveforms, and so it can then give us a picture as far as where the Impella is actually sitting in relation to the aortic valve. So again, that we can have an additional confirmation and visualization of the placement of the Impella device. Adverse events, this is a mechanical circulatory support. It's going in through the groin, so it's typically a larger cannula. There is the risk that patients can die from this procedure, and so again, very careful patient selection, as well as the cardiovascular specialist or the cardiac surgeon's experience with these devices is extremely important. Again, the aortic insufficiency can develop as a result of having the device in place. Bleeding, hemolysis, infection, perforation. So again, very careful management of the catheter, making sure it doesn't migrate. Obviously, the risk of stroke, again, tamponade. The pigtail is designed so that it doesn't touch the left ventricle, and because again it can be very sensitive, and so if it migrates in too far, even though the pigtail is rounded, it can still cause a VFib or VTAC arrest, arrhythmias, as well as vascular injuries, because again it's a large catheter that has to be threaded all the way up through the aorta, across the arch, and then into the left ventricle. When we look at more durable mechanical support devices, then the Thoratec is one of the first devices that was ever utilized. The monitor that is shown there on the left-hand side, the great big console, that console is very large. It's probably about 4.5 to 5 feet tall. It's a pneumatic dual drive console, so again it's a pneumatic pump on the inside, and it probably weighs close to 500 pounds. So very huge device, but it is still one of the mainstays of treatment for patients. It was first used in 1982. The beauty of it, again, it can be used for right or left support, or BiVAD support if necessary. So again, was utilized for bridge to transplant, and also patients that were failure to wean from bypass, they could also elect to cannulate. I've also seen this used for patients that need long-term support, and they've developed possibly an infection, a pump pocket infection, or things like that. And so we can put this device in until we clear the infection, and then they go back and convert the VAD to an implantable type device. So the picture there that is seen, the two pumps at the bottom, the two circular components are the pumps, and those are actually then inserted through the chest wall. So typically requires open heart surgery to get the access, and then they thread the cannulas through the chest wall, and so the pump themselves actually live outside of the body. So typical cannulation will go from the left atrium directly into the aorta. So we decompress the left ventricle, and that's what determines our flow. If they have bilateral support, then left atrium to aorta and right atrium to the pulmonary artery for bilateral support. So that's what the pump looks like. The cannulas then go into each side of that circular device there, and then the drive line is the pneumatic drive line. It has a fill switch, so basically one part of the pump is going to create a sucking effect or a negative effect that's going to pull blood out of the left atrium and out of the heart, and then once there's a bladder on the inside of the device, and once that bladder is full, then it will then trigger the pneumatic part to push it blood. So it basically sucks and pushes that way. And so most times when we talk about a VAD, it's usually VAD centric. So the inflow valve is typically what's coming out of the patient into the VAD, and the outflow valve is what's going out of the VAD to the patient. So sometimes it can be confusing, but most of the time when we talk about VAD therapy, it's device centric. So the inflow is into the VAD, outflow is out of the VAD. Other types of ventricular assist devices, the HeartMate II, also developed by Thoratec, same company. This is the next generation. The first generation was the HeartMate XVE, which was a pulsatile pump, and it was a circular pump about the size, a little bit bigger than a hockey puck. And then the next generation is an axial flow. So the device itself is in that picture that you see underneath where it says HeartMate II. The silver part is the actual pump itself, and so basically it is an impeller type device or an axial device that spins. Cannulation then is at the apex of the left ventricle, so it pulls the volume out of the left ventricle and then pumps it directly into the aorta. The white line that you see then that's coming across the patient out to that kind of tan colored, that's basically the pump monitor. That's called the drive line. So typically the VAD is placed obviously on the left side. Drive line is tunneled across the right and then exits the abdomen on the right side, typically with that. So patients learn to, this is an implantable, completely closed device. So patients then, once this is placed, then learn how to care for the drive line. They learn how to prevent infection, doing their dressing changes. The patient in the picture, or the model in the patient, basically those two black things over the shoulders are two battery packs. So again, they can have either tethered function to the larger monitor, or they can do battery for mobile monitoring for that. And so again, the interesting thing with the HeartMate II is that it's going to depend on how much native flow and native function we have with the left ventricle. And so if they have some contractility with the left ventricle, then they'll have somewhat of a pulse. If they have very minimal ventricular activity, then they may not have a significant pulse. And so these type of devices, then your assessment again is driven off your mean arterial pressure, and again your pulse pressures may be very narrow, and it's okay because the pump is providing the perfusion and our pulse is derived from the heart squeezing. And so if the heart isn't squeezing very much, we're not going to see much of a pulse, but that's okay. They'll still have adequate perfusion, adequate MAP, and that's what guides our therapies with that. So there's an x-ray with a patient, and you can see on the x-ray that again they've got a pacemaker that's implanted as well. You can also see the ring right above the VAD implant itself, and you can see a ring, so it looks like they've had some work on their valves there. So again, looking at the aortic valve. So interesting x-ray when they have lots of mechanical devices inside of the body and inside their chest. Heartware is also another ventricular assist device, and it is also implanted in the apex of the left ventricle. And this device, as you can see in the picture of the hand, it actually goes directly into the left ventricle, into the apex. So they kind of core the apex, put the device in, and it pulls directly from the left ventricle, and then that the cannula then goes directly into the aorta. So again, it's pulling right out of the left ventricle and pumping it directly into the aorta to support systemic perfusion. CenterMag is also, this is a considered more of a short-term device. This is designed as an extracorporeal, so it lives outside of the body. The pump is that little circular part. It's made of plastic, and it has an impeller device in there. It's magnetically levitated, so once it sits in the motor housing and snaps in, then the impeller becomes levitated, and then the console controls how fast that impeller flow will spin. Most of the, one of the more important concepts to understand with any type of ventricular device is that they are very much volume driven. So again, if we aren't monitoring their intake and their output and patient's volume status, some of these devices will keep spinning no matter what, even if there's not blood there. And if that happens, again, it can suck the ventricle down. So critical understanding of hemodynamics and fluid management is extremely important for these patients, and especially when we have a new device being put in, so that we know exactly how much volume that patient needs and making sure that they don't develop any complications associated with that. The CenterMag also can be used for left-sided or right-sided support, or both if indicated. And then other causes of heart failure that is now gaining more exposure into the media and into literature and studies is related to structural heart disease. Typically when we think of heart failure, we think of a bad pump. Heart's not pumping well, and that's the reason why the patients are in heart failure. With structural heart disease, these patients, it's not so much the heart muscle, but there may be structural changes that inhibit the ability of the heart to function normally with that. So again, looking at structural heart programs, then it looks at typically the valves, and so again, if they have any type of aortic stenosis, when the aortic valve doesn't open properly and that left ventricle has to work like crazy to get the valve to open, again, they'll have symptoms of heart failure, but in this case it's not because of the pump, but it's actually because of the valve and the structure with that. So again, in the last 10 years, just tremendous amount of advances with these structural heart programs, looking at therapeutic modalities to help patients with structural heart disease. And if we can fix the mechanics of the heart, then many times their heart symptoms are alleviated, and the patients seem to do very well. So again, looking at technology, multiple clinical trials all across the country and Europe are being utilized. So it'll be interesting to see over the next few years how much impact we'll see that as far as our treatment options for these patients. So again, our normal blood flow from the right atrium through the tricuspid valve into the right ventricle, through the pulmonic valve into the pulmonary artery, and then the blood is oxygenated in the pulmonary vasculature, returns through the pulmonary veins into the left atrium, through the mitral valve to the left ventricle, and then out the aortic valve to the aorta to provide systemic perfusion. So when we have structural issues, if we have an atrial septal defect, or if we have a ventricular septal defect, now instead of the blood moving out to the aorta where it's supposed to, the pressures on the left side are much higher than the right, and it'll cause the blood to move over to the right ventricle. So again, if there's any septal defects, patent foramen ovale, any of those type of structural changes, then we need to make sure that they are closed appropriately, whether it's through surgery or percutaneous closure devices, to maintain the 4 chambers of the heart. If we have valvular issues, so valve insufficiencies where the valves aren't closing properly, or if we have valve stenosis where the valve doesn't open very well, again, can have significant impact to our overall cardiac output. So when we have valve issues, then we typically will hear extra heart sounds. We'll hear murmurs associated with that. And so again, common to have murmurs with patients with heart failure. The 2 types of disorders we can have is a stenosis, where we have a stiff valve that doesn't want to open, and that's going to decrease forward flow of blood if you have a stiff valve that doesn't open or a very narrow lumen to that valve. And then insufficiency or regurgitation, where we have floppy valves that don't close. Typically the insufficiencies are what we'll see with advanced heart failure, but patients can have stenotic valves, and then those patients will look like they have heart failure. So again, and it can be a systolic or diastolic problem just depending on which valve is affected by that and which chamber of the heart. So looking at this table that I put together, it's mainly to look at systolic versus diastolic and right-sided versus left-sided. So we'll start on the right side, and we'll start with diastole. And anytime you're thinking of diastole, I want you to think 2 things. I want you to remember filling and feeding. We're filling with stroke volume, and we're feeding the coronaries, and that's providing perfusion, and so that's going to tie into patients with ischemic disease. So during diastole, the tricuspid valve is open, and we're supposed to be filling from the right atrium into the right ventricle. If I have tricuspid stenosis, so that means I have a stiff valve that doesn't want to open, or it's got a very narrow lumen, narrow opening with that, that's going to impede volume moving from the right atrium to the right ventricle. That's going to decrease stroke volume or filling into the right ventricle, and that's going to decrease the volume that makes it over to the left side and will result in decreased cardiac output. If I have a pulmonic insufficiency, so the right ventricle had systole and squeezed, push the blood out the pulmonic valve, but now those cusps on the pulmonic valve don't close. So now the blood that it's pumped out, when the ventricle relaxes and starts filling, part of that blood's going to fall right back into the right ventricle where it just came from. So when it's squeezing, it goes up and falls back in. It goes out and falls back in. It goes out, falls back in. So again, minimizing the effectiveness of the pump so that, again, you don't have adequate forward flow. Now systole occurs in the right ventricle. If your patient has tricuspid insufficiency, when the right ventricle squeezes, part of the blood goes out the pulmonic valve to the pulmonary system, and part of the blood will go right back up into the right atrium where it just came from, because the tricuspid valve leaflets don't meet any longer. So again, minimizing the effectiveness of the pump. So blood is basically going in 2 different directions with each systole. And then if we have pulmonic stenosis, where we have a stiff valve that doesn't want to open, again, when the right ventricle squeezes, if it can't get that valve open, or if it's a very narrow opening, then it's going to have to work harder to push the blood volume forward. You're going to have decreased stroke volume moving forward on the right side, and obviously that's going to impact the volume coming over to the left side. Same holds true on the left side. So during diastole, if I have mitral stenosis, it's a very stiff valve that doesn't want to open, harder for the left atria to fill the left ventricle, so the net effect is decreased stroke volume moving forward, and that will lead to a decreased cardiac output. If I have aortic insufficiency, then part of the blood we've already pumped out the aorta, when the left ventricle relaxes and is filling, then part of that blood's going to fall right back into the left ventricle where it just came from, because those cusps are no longer meeting and closing appropriately as they need to. Now systole occurs, so again, if we have mitral regurgitation or mitral insufficiency and those leaflets don't close, when that ventricle squeezes, part of the blood is going to go out the aorta, most of the blood is going to go right back up into that left atrium where it just came from, because the pressures in the left atrium are much lower than the pressures that we see in the aorta. And then with aortic stenosis, then that left ventricle has to work really hard, push that blood forward to open up the stiff valve. So again, decreased forward flow of volume, and again, decreased cardiac output that's associated with that. So sometimes, valve disorders can be confusing. But a good rule of thumb to think about when we look at primarily the biggest impact is when they have valve disorders on the left side. So a good rule of thumb, if you have a stenotic valve, whether it's mitral or aortic stenosis, we know the net effect is decreased volume moving forward, decreased stroke volume, decreased cardiac output. Those patients typically will see activity intolerance first because they have a low cardiac output. And then eventually the blood starts to back up and backs up into the lungs, and then they get the pulmonary edema, pulmonary congestion, and hypoxia. So if they have a stenosis, we see activity intolerance first, and then it's followed by the pulmonary edema and pulmonary congestion. If you have a patient that has an insufficiency, so again, on the left side, whether it's an aortic insufficiency or a mitral insufficiency, when you have a valve that doesn't close well during systole or during diastole, you've got immediate backflow of blood. So blood is backing up and backing up and backing up into the lungs. And so those patients typically will have signs of fluid overload, pulmonary edema, and hypoxia first, and then they develop the activity intolerance because they're hypoxic. So that's a good rule of thumb to think about with valve disorders when you look at the patient's symptomology and what's the typical picture associated with that. With aortic stenosis, again, very small volume moving forward. So again, they're going to look like a heart failure patient, especially with aortic stenosis. Most valve problems we will try to manage medically for as long as possible, and then they determine whether or not surgical intervention would be warranted to either repair or replace the native valve. So specifically looking at aortic stenosis, it affects millions of patients in the U.S. So again, uncontrolled hypertension, it's the most common type of valvular disorder with elderly patients, usually results from calcification of the valve leaflets, affects over 250,000 people that have severe symptoms of aortic stenosis, and once their symptoms become severe, then life expectancy greater than 2 years is less than 50%. So most people die within 2 years once the stenosis becomes significant with that. Many times, again, this is the most common type of valvular disorder with our elderly patients, and so again, many times these patients are considered non-operable. They have decreased cardiac function, they have decreased pulmonary function, they have decreased renal function, so many times they aren't a surgical candidate. Again, management is medical until it becomes severe, and then the gold standard is still open heart surgery to replace or repair the valve. So again, traditional measures are still the mainstay and the gold standard for that. But again, when you have patients that are considered non-surgical, historically there had not been any other options for these patients. And now through advancements through structural heart programs, now they look at the transcatheter aortic valve implants or aortic valve replacement. So you can hear it referred to as TAVI or Tavor, where we're either, they're both the same process, same procedure. It just depends, what area of the country. Some places call it TAVI, some call them Tavors. So with a Tavor or TAVI, Historically, this is a relatively new procedure within the last probably 5 years that we've started to see this type of device with that. Not all facilities have the capability of doing this type of approach, but typically it's a transfemoral approach that they put a catheter in the femoral artery. They thread that catheter all the way up across the arch and across the aortic valve. They do a valvuloplasty, so they balloon up and stretch those valve leaflets, and then the second time they balloon up, then they deploy an artificial valve. So they don't remove the diseased valve, they just kind of press the leaflets out of the way and put in a new valve within that. And so it's almost like a really large stent with leaflets on it. So again, the advantage is that they don't have to go under, the sternotomy procedure, and again, you have many advantages associated with that. They can also look at a transapical approach or a transaortic approach, depending on the patient. So again, different approaches, but basically the same procedure where through a mini thoracotomy, then they access the heart that way. Obviously, with the transapical or transaortic approach, then there's a lower risk of stroke with that. If they can't do transfemoral, then they will look at the transaortic, and again requires a mini sternotomy or thoracotomy to do that. So again, this is a viable option for non-surgical candidates in the U.S. Currently, FDA approval is for patients that are deemed non-operative candidates for that. Again, what we've seen as far as the results is that very similar outcomes in mortality, significant decrease in symptoms, and improved hemodynamics as seen with the surgical patients, but obviously a lot less complications and the fact that they don't have a sternotomy associated with that. So pre-op workup for these patients, it is extensive. So you will never see an emergent TAVI where somebody comes in through the emergency room and we're going to send them for a TAVI or a Tavor, because it requires extensive workup to make sure that they have appropriate access and to make sure this patient is an appropriate candidate. So not only do they look at the ECG, the echocardiogram, and measure the ejection fraction and measure the cardiac function with that. They'll do a CT of the chest and abdomen and map out all of their internal structures, specifically to the aorta, and making sure that that catheter can be passed from the femoral artery up through the heart, up through the body into the heart. So again, vascular access is extremely important with that. Left heart catheterization to measure, again, the coronaries, make sure they have adequate flow to the heart muscle and that won't be impaired. They'll do a gated CT, which also measures the coronary ostium and measures where the coronary arteries originate. If we have that aortic valve sitting there and the coronary ostium is just distal to the aortic valve, if we resect back those valve leaflets and compress them against the wall of the aorta, if those leaflets are longer, or if when they're resected, when they're flapped back, when they put the valvuloplasty and do that, they may occlude the coronaries, and obviously that would be very bad if we occluded the coronaries. So they want to make sure that the patient's leaflets are appropriate so that when they do the valvuloplasty, they don't occlude the coronaries with that. So x-rays, labs, renal function, liver function, pulmonary function tests, extensive workup. Usually requires at least 2 weeks of multiple studies to make sure, and then each case, the whole team, the structural heart team, then looks at the case and looks at risk and benefit before they determine whether or not a patient is a Tavor candidate. There's currently 2 valves available through the FDA in the U.S. at this time. The Edwards valve is the Sapien valve, and that's a picture of it. So again, can be deployed through multiple approaches, so either transfemoral, transapical, or transaortic with that. And you can see it looks very similar to a stent. It's got the skirt at the bottom of it, the white part, and then the tan part are actually bovine leaflets that are hand sewn to the skirt of that, so that when it's crimped down over the tip of the catheter, and then when they do the balloon valvuloplasty and opens it up, then it opens up that valve and it remains in place. So looking at a couple pictures here, the blue catheter then is what's advanced across the aorta, and so the tip of the catheter is yellow. They usually put in a pacing wire first, and so then they'll do rapid pacing, and so basically creating a ventricular standstill when they do the valvuloplasty part of the procedure. So there you can see they've ballooned up. The valve itself is actually crimped down on the end of the catheter. So they balloon up and make sure the valve is exactly where they want it to be. And then they balloon down and withdraw the catheter. The green wire is that pacing wire that's left behind, and that will be the last thing that comes out. So the valve remains in situ. It is not sutured in. That's another big question. Everyone's like, can it migrate? Does it fall out? And again, placement is critical, and so there have been no cases of migration or anything like that. So even though it's not sutured in, it's quite stable and stays where it's supposed to be. So there you can see what it looks like in situ. So we haven't removed the stenotic valve. We've just kind of compressed it out to the side, and now we have a new functional valve in the middle. The amazing thing with these valves is that the effects are immediate. So one of the first cases that I was able to observe, there was Transesophageal Echo is being done. It's usually done in a hybrid OR within the cath lab. So not only do you have the surgical team, but you have the cath team, you have the cardiac surgeon and the interventional cardiologist working together, which is a nice component, because before it was always medical and surgical, and now both teams are working together. Your cardiac anesthesiologist doing the TEE, so everybody is on the same page as we're doing this procedure. The amazing thing with the first case that I saw was on the echo, I mean, you could see just minimal movement, hardly any blood flow coming out the aorta, and just minimal movement. And then after they placed this and the heart starts pumping, just phenomenal how much the blood flow has improved. Most studies have shown, looking at these different types of procedures, is that after we fix the valve, their symptoms of heart failure are immediately alleviated, and we have improved perfusion. So usually their renal function improves, their liver function improves within a matter of days. So really quite dramatic effects associated with this. The next valve that you see on your screen there is the core valve, and this is the valve that is manufactured by Medtronic. A little bit different design, a little bit different deployment, but very similar, obviously clinically very similar effects with that. So again, it's basically this structure that has the leaflets then sewn in, and they have porcine leaflets. So looking at the figures there, again, through a retrograde flow across the aortic valve, and so you can see in figure 1 as the catheter is approaching the aortic valve. Figure 2 then, basically then as they deploy and release the device then, and it opens up, and it'll continue to open over a period of 2 or 3 days post-procedure. And then it remains in situ again, and again not sutured in, just strategically placed is important. Things to think about with these type of devices is that, because again it's a metal device that we're putting in the heart, so you want to be careful about conduction issues and blocks and pacing and bleeding and all sorts of other complications associated with that. So obviously extensive training is required to care for these patients post-procedure. So there you can see what it looks like then post-procedure then, as it is situated again inside the native valve, but now it's compressed against the vessel walls, and so no longer part of the blood flow, the natural blood flow of the blood out of the left ventricle. So this concludes this module about management of advanced heart failure and devices.